Hello, everyone. So we're going to be talking about the future of stroke care from triage to treatment. So now that in Barcelona, everybody's going straight to the cath lab, in America, we're not doing that yet. And until we do, how you can improve your door-to-needle, door-to-device times, and improve your patient outcomes. So these are my disclosures. So a little bit about our program. We did about 1,200 neuro cases last year at Valley Baptist. This year we're on par to do about 220 strokes. We are now 3 endovascular neurologists. We have 3 biplanes and a monoplane that we actually did use for a stroke even after the 3rd room was installed. And we've been a part of several stroke studies and research studies. Most of you know this data already, but there's a reason I'm putting it up. We all try to improve patient outcome, but time is the key. If we can get patients treated faster with IV thrombolytic, if we can get patients to cath lab faster, we know we can get better outcomes. Yes, we have the slow progressors. We shouldn't have to rush those patients, but you don't know that until the patient is gone through our system, unfortunately. When you have your drip and ship patients, when you have your patients at the spokes, there's so many issues that can occur. So we should treat everybody as if they're a fast progressor and try to treat as soon as possible. So one of the things that we want to talk about is mechanical thrombectomy rates are low. And I know Dilip, if he heard me, he'd be very happy that we're stressing this, right? That's the whole point of the MT 2020 initiative. We need to improve mechanical thrombectomy access throughout the world, but even in the United States, where we have it available in every major market, probably several centers. If you look on the column on the right, metro regions with the lowest rate. 2% in Boston, 2.5%. 2% in the Washington, D.C. area. San Antonio, 2%. Versus Colorado, Denver area is doing about 9.3%. So I'm sure you know some of the interventionalists there and how aggressive they are. But some of these numbers might be swayed due to volumes, right? We know that several states transfer to Denver. We have someone here from Billings, Montana, and he doesn't have an interventionalist. So the whole state of Montana is transferring to either Utah or Denver. So make a long story short, our mechanical thrombectomy rates are low. We all believe they should be at least 15 to 20% of the United States, and most markets are nowhere near that number. Then on top of that, by having this wonderful data from the DAWN study, we know that we can actually improve that total number. We have a lot more patients that can get treatment, and we've opened up the window. But if you look at the treatment times, I'm sure you've all read the Stratus paper by Mike Froehler. Transfer times for patients who were transferred, the treatment time was 5.2 hours on average. If the patient was directly admitted to a mechanical thrombectomy center, it's 3.8 hours. And there's a significant difference in outcomes. So going to the right place the first time is important. But in rural areas, in markets that are spread out, like in South Texas where I'm at, you're not going to bypass a primary stroke center for 45 minutes to come to a CSC every time. We have bed shortages. We already are expanding our neuro ICU by 14 beds because we're always full. So I don't want every patient, and neither do you. As an interventionalist, you don't want every patient. You want the patient you can help. Increased cost. So there's a lot of data showing about $1,000 in benefit of thrombectomy per minute delay. So focusing on improved treatment times, getting the patient to the right center the first time, definitely dealing with the futile transfers and increased volumes, and then last but not least, provider burnout. How many of you, you have a rough week, you've done 6, 7, 8 mechanical thrombectomies. I mean, my co-fellow in training was Dr. Gregorian, and he texts us sometimes that this is the 3rd case I've done this night. And I'm sure you all have similar scenarios. So we're all going to burn out sooner or later. So we need better tools to help manage our time, manage our space, and still improve time to treatment. So you've all seen this data before. Time is brain. Large vessel occlusion loses 2 million neurons a minute. Now, what does that mean? Time is brain and 2 million neurons. Patients, EMS, they want something more concrete, right? Who cares about 2 million neurons? They don't understand it. But when you tell them for every 20-minute decrease in a treatment delay, you lead to a 3-month gain in disability-free life, okay, that makes a lot more sense. So imagine, and this is 20-minute decrease. What were the times? Do you guys remember the times in IMS3 from CT to puncture? Over 2 hours. If any of you did that today, you'd probably, fire half of your staff and change things up, because that's not acceptable. Now it's door to device of 90 minutes. Patient comes into your hospital, door to device of 90 minutes. And CT to device, or CT to puncture, was 2 hours historically. So we have a lot to work on, but we have improved significantly. So how do we get more patients faster and better? So technology is one way. So we've done a lot of research. We called it the STEPS-T project, and it's all about stroke triage and procedure standardization, and that focused on the angio suite to recanalization time. But now, after fine-tuning that for several years, and I'll show you that data in a bit, we noticed that we're not really improving the onset to treatment time as much as we would like. So how do we do that? So number one way is early detection, and then rapid triage and synchronizing the care, the whole team being on the same page. So here's an example. This is a quote by world-famous neurologist, Dr. Tom Devlin. And the idea is, I'm getting an alert when my stroke centers across the valley, 20, 30, 40 miles away, get that stroke. And I'm getting an alert instead of getting a phone call from a neurologist who previously got the phone call from the ED doctor, who previously got the phone call from the radiologist that there might be something going on. So we're all tied in together and we're getting alerts, right? It's a push alert on your phone, whether you have an iPhone or an Android. This is just to show you what 1.9 million neurons is, right? It's that little spot on diffusion that you keep saying, oh, it's just a small spot on diffusion. It's 1.9 million neurons. Ages your brain by 3 weeks. So here's an example of what goes on currently at one of our spokes. So Brownsville, Valley Baptist Brownsville is a sister tenant facility. Tech is going to post-process that image. CT, CTA, they did not do CT perfusion early on, and now they're starting to do it because, again, we're always full. Radiology preliminary read, typically 20 to 25 minutes. Then the radiologist is calling the ED doc. He doesn't even call the neurologist. ED doc then calls a neurologist, neurohospitalist at Valley Baptist, who calls endovascular, whether it's myself or Dr. Techley. Then I say, okay, let's transfer the patient if you think there's a large vessel occlusion. I haven't seen the image. Then he calls his house supervisor, who calls my house supervisor, who calls me to accept the patient. You see how many calls? So the idea of Viz and synchronizing all of this is that I get the push alert. If I'm in a case, I hear that beep, right? There's a distinct tone when it's a large vessel occlusion alert. When I get the patient, and if I'm out dealing with another case or rounding in the neuro ICU, I get a call or I get a message. But already everybody on the team has figured this out. Stroke coordinator, neurohospitalist, ED physician at the accepting hospital, and ED physician at the spoke, endovascular team, research, all of us are on this Viz hub, and we're all messaging each other and talking about what's going on. So typically patient shows up to our stroke center and you'll get the alert. I like the fact that it pushes to your Apple Watch. I'm not sure if you have Apple Watch or not, but I always cover my Apple Watch with my glove. I know neurosurgeons hate it, but I can see red is dead, green is go, and we're taking patients and we're accepting them faster. But let's run a clinical case. 69-year-old, last known well, 2 p.m. Arrival, door in, 6:02 p.m. So already 4 hours from onset. Suspected stroke, whole gambit is done, CT, CTA, CTP. 6:26, the CT angiogram is acquired. 3 to 4 minutes is the average time for the alert. At 6:30, suspected large vessel occlusion, you hear a special ringtone, you get the push alert, you're seeing on your phone, you're seeing on your watch, and you look at the images and you decide what to do for this patient. Now, if I'm in a case, if I am not responding within a minute of that alert, this is why really we truly love this as a system. My neurohospital at Valley Baptist Brownsville is like, hey, Ameer, are you on call? Or Wendy, whatever, he's gonna text, hey, who's on call? I'm not sure this is a large vessel occlusion, or maybe this patient it's a chronic occlusion. I saw this, I didn't see this. He feels like he's part of the decision. We're all making this decision together. I got an alert yesterday. During one of these discussions, I'm looking at the dialogue between Techley and them, and it was an old vert dissection, and supposedly we had taken a picture 4 or 5 years earlier on this patient. So we already knew, but that dialogue, everybody's on the same page, and the transfer is canceled. Not a single phone call. Within 2 minutes, this is all taken care of. Now, if the patient is a true large vessel occlusion, he's messaging me, hey, Ameer, this is an NIH at 20. This is what happened. He's giving me that information. And everything is go, go, go. Everybody's on the same page. My coordinator is on site before that transfer hits the door, even in the middle of the night. Now, they can turn themselves on and off. For those of you who don't know about VIS, we can talk about it later. So 6:30, large vessel occlusion alert. 6:32, TPA was given. So looking at some of this data from an early study, picture to CSC notification. And this is very close to our numbers, 82 minutes. This is from 2 references. 4 minutes with VIS. Door to angio suite time, average 2 hours. And this is historically. We have an abstract about this, looking at the 2 years pre-VIS and the 1 year post-VIS, and we got it accepted as a moderated poster at ISC, so you'll see it there, but we saw significant improvement in transfer times and outcomes. Direct correlation. Treat faster, better outcomes. So in this case, door to angio suite, 123 minutes, with VIS, 39 minutes. So again, there's the large vessel occlusion alert, there's a CT perfusion if you want to look at that. I'm not going to get into argument whether we think we need CTP or not. If Amru is here, we're going to agree. Aspects is enough. Go, go, go. VIS view is your CT, so you can see your CT non-contrast, and then the hub. And again, if you're looking for something to drastically improve the time at your hub, your comprehensive stroke center, this is not going to be enough. You need to work on everything, working with your ED, educating your team, improving your transport. You got to work internally. You want something that will quickly, within 30 days, improve your transfer from all your spokes. This is a solution. So correlation of VIS CTP versus rapid, it's pretty good. As you can see, 95 to 97.5% with some of the Dawn patients. And this is published data by Raul. Motion artifact. So 50% fewer motion artifact errors. So this is pretty cool because I'm sure you all have rapid if you're study sites or you had rapid at one point. And we used to always call it alien brain. So there has been some improvement on both ends. Not gonna, rapid's definitely improved from the early days when we were Swift Prime site. And VIS has even taken a step further. Here's another example of the motion artifact. And this is, I know they have an app now, but, this is just, it's so cutting edge, it's so sleek. And we have the app for both, right? I have several comprehensive stroke centers now. I'm slowly going to be losing my hair, but it's good to see. I love competition, right? Why does solitary retrieval keep getting better? Because you have somebody else. EmboTrap is trying to show improved Tiki-2C3. You have better Jet 7 because of React. You have to have this competition. So rapid wasn't going to improve if it was only rapid. So getting everybody into the game is improving patient care, and that's what we all in this room should care about. So I don't care what side you go to, but you should strive for competition and improvement in all of our devices and all of our technology. So now let's quickly talk about reducing the setup time. We called it STEPS T, Stroke Triage Education, Procedure Standardization and Technology. We had a paper a couple years ago about this and how we standardize workflow. We work with in-house educators and the vendors, getting everybody on board, dividing the pathway, and everybody knows what to do for a stroke. There are no calls, there are no text messages. The only question they typically ask me, Doc, right carotid, left carotid, or are you going radial for posterior circulation? That's all they ask. Everything else is standardized. So what did we find? Intervention time significantly improves with implementation of this program, and you see a constant improvement in intervention time the first year and a half of the program. But then it plateaus. And that's why I said, if you want to really improve in-house stuff, there's no really quick fix. But you want to improve your spoke to hub transfer time and treatment time, there's a solution. As the treatment times improve, top left graph, you see that modified Rankin continues to improve. But the Tiki from 2013 to 2017 is basically flat, right? Devices haven't really improved. Our techniques, whether you're ADAPT user, Salumbra user, Balloon Guide, TRAP, Badass, Captive, there's like 55 acronyms now. I can't keep up with them all. But the idea is it's not technique, it's not device, it's not just time. It's all of them combined. Everything in combination is going to improve treatment. And treatment times improve outcomes. So discussing triage to treatment, Solitaire X is a new revascularization device I'm sure most of you have been using recently. Nicer profile, much easier to advance. We are big Phenom 27 users. We used to be Marksman 27 users because we liked the extra length and we liked velocity. We always wanted that extra length. Now with the Phenom 27, it's a rail, right? Nice big microcatheter. You take it up there, it's easy to bring up your Jet 7, your React 71. Your distal access catheters really go up much smoother, much faster with a Phenom 27, 160 centimeter. So we really like it. And we typically use it with an 18 wire. And we can talk about that offline if you're interested. There's the React 68, React 71. I gotta say, we always use React 71. In our shop, it's always React 71. Tech is a big ADAPT user now over the last several months. Always will do 2-3 passes first with ADAPT. If it doesn't work, he'll open a stent retriever. And a lot of that logic is about cost. He's planning on building a center in Ethiopia. They don't have any stroke treatment there, so he's really concerned about cost. So you're gonna go for whatever's cheaper. My go-to approach is React 71. In this case, Phenom 27, 160 centimeter. And we're gonna use a Solitaire 640. I use 640 all the time, even for branches. It's got lower radial force. I see less dissections and less perforations. So optimizing delivery, the delivery force is significantly less with Solitaire X compared to Solitaire Platinum, 47% lower delivery force. So if you want to use a 21, you can use the Phenom 21. There is significant improvement in that, and whoever wants that lower profile will use the 21. Or if you're like Mikhail, you're never going to cross the clot anyways, you're just going to kiss it and then bring up your aspiration catheter and then start your ADAPT technique. Increased length. I don't think any of you should be doing stroke without 160, 157, even 165 microcatheters. That's the future. You should do it, especially if we're going to start treating more distal occlusions. I know there was a distal meeting yesterday in the morning with some interesting data and hopefully a future trial. So this is an interesting case. This is a polectomy with a patient shot by his brother-in-law with a shotgun. Yeah, you heard that correct. Brother-in-law. 44-year-old man. EMS finds him at the site, quadriplegic, loss of consciousness, they intubate him. Trauma calls me and says, we have a basilar occlusion in the trauma patient. I see there's a bullet in the head. I'm like, are you kidding me right now? I was actually in a case, went down, and we looked at it together, and sure enough, there's a pellet that dissected the left vertebral artery. He got shot in the left shoulder, dissected the left vertebral artery, and this shotgun pellet went into the basilar tip. So high NIH, confirmed basilar large vessel occlusion on non-invasive imaging, and we basically kiss it with the React. And as you can see here, I'm slowly just pulling it out. And all I did was just turn on suction and kissed it. Didn't pass a microcatheter past it or a wire, just got right proximal to it. And then here in the V1 segment, I'm thinking, okay, this is not coming into the React. Is it gonna come into the Neuron Max? And I was a little concerned, to be honest. And I said, well, let's try it. Just keep the continuous suction on. Do not turn off that pump. And we pull it in slowly, as you can see here in the video. And what happens is, obviously, the React 71 is getting pulled into the Neuron Max, but that suction is still strong enough to keep the pellet at the distal tip of the Neuron Max. And as you can see here, when it comes out,
Sir, can you
it is at the end. I don't know if you can raise the volume of the video.
I'm back with a 12 gauge.
This is the patient next day.
And one of the pellets went into my head. And Dr. Hassan was the one that helped me out recovering myself, my body. I can move my arms, I can move my legs.
So he couldn't move anything, and now he's moving his arms and legs. And he's gonna do a little dance for you on his feet. Look at that. So very exciting case. It was accepted to JNIS, so you'll see it shortly. So now let's talk about thrombectomy, right? I hope none of you get shotgun patients with pellets in the basilar tip. So 72-year-old male, last known well, 6 a.m., presented to our stroke center at 7:43 p.m. So you read that right, last known well, 6 a.m. Presents with NIH of 18, left hemiplegia, dysarthria. Head CT and CTA are performed. These are the images, literally a screenshot off of my phone. And we'll go take the patient, React 71, under constant aspiration, groin or recant, 10 minutes. That's it. It's Not going to show you any tracking, anything special. It's just a very flexible catheter, very easy to advance, and with one pass we were able to do adapt. This was actually Dr. Techley's case. So where's stroke headed next? Advancement of patient triage and detection, I think, is the key. There's a recurrent theme for anybody who cares about onset to reperfusion, right? Yes, groin to reperfusion is important, and for your metrics, so you can get your AHA awards, door to reperfusion, door to device, door to TPA is all important. But onset to reperfusion is what you should care about. As a neurologist, as an interventionalist, as a stroke doctor, as a nurse, wherever you are in this stroke care continuum, this is what you should care about. And that's what we need to work on. Further expansion of the time window. I know a lot of friends who yes, the guidelines now say you should follow diffuse 3 or Dawn criteria. We throw that out the window. It's imaging based at that point. If it's not a thrombolytic candidate, get CT, CTA, CTP. I don't care if he was last known well 3 days ago. And I think Andre told us about a 4.5-day case, him and Tudor, supposedly when they were residents. Breakthrough technology to improve first pass effectiveness. I think this is the future of stroke devices. So without saying any names, any devices, any companies, I've seen probably a dozen new devices in the last 2 days. Signed a bunch of NDAs. And yes, I like to, again, competition is good. But if you're not going to improve first pass effect, what's your point? Just have a Me Too device? So this is something that we as interventionalists need to push for. I want a device that's better. You have to show me why it's better, not the same, not a Me Too device. And then post-treatment therapy. I think a lot of companies, I'm sure you heard about some of the stuff going on in the tech suites today, really cool stuff about rehab, right? The patients that we do recanalize and it's futile and the patient doesn't improve. I don't like the word futile recanalization, but still, you have patients that don't improve. You have patients that come in and it was too late, right? Aspects of 2. You're not going to take that patient. So what are we doing for these patients? And hopefully this new technology will continue to improve outcomes. Conclusions, even with extended treatment windows, time is key. You should always continue to improve your treatment times. Improve door to recan by reducing the pre-interventional time with products like Viz AI and stroke team education. Over a 6-year period, our integrated program, STEPS T, allowed us to standardize our stroke treatments, significantly improve time, recan stayed the same, and you see the modified Rankins continue to go up. New technology will help further drive innovation and improve outcomes, and Medtronic has a new portfolio of devices like Solitaire X, Phenom 21 and 27, as well as the React catheters, Riptide, and the partnership with Viz AI. Thank you very much, and I'll pause for some questions.